We have two excellent moderators, Sharbani and also Joanne Manrique, Sharbani Chakraborty. And Sharbani's first panel, will discuss more of a high-level aspects of financing NCDs. We're joined by representative from WHO. We'll get a better introduction from Sharbani, and also from a very prominent civil society organization, UICC, and also Gene Buckman from Harvard, the NCD, really the NCDI for the NCDs and injuries for the poorest 1 billion. He was the Lancet co-chair for that. And we'll get a high-level perspective on how do we be inclusive, and how can we take an integrative approach to financing. That will be the first hour. And the second hour will have a deeper dive hosted by Joanne Manrique, with really really an expert on impact investing as a panelist, as well as a development specialist whose area of expertise is in Africa, looking at the back end of delivering NCD care in supply chains and things like that. So I hope this next 2 hours will really enlighten you on how do we take a integrated and inclusive approach to capitalizing. And we chose that word carefully. We didn't want to just say financing, because we really think of this as what are the monies available, right? And how do we use it in a smart way? So let me first turn it over now to the first session moderator, Sharbani Chakraborty. She's a dear friend of mine. She's worked at the World Bank in the past for over 2 decades. She is an expert on global health financing and also global health, public health practice. Currently at the senior researcher at Technical University of Munich in Germany. Sharbani, can I turn it over to you at this time?
Sure. Thank you, Key, for the introduction. So good morning, good afternoon, good evening to everybody who has joined us today. Key just gave us a quick overview of what we'll be covering. So the first panel will be taking a sort of a high-level view on financing. And what I wanted to mention is that in a lot of my conversation with ministries of finance and ministries of health on NCD financing, which you know is underfinanced globally, especially in low and middle income countries, one of the things that I was hearing a lot is, what are the models of care? How do we do it? Because even if we raise the money and the money is pooled, ultimately we need to show impact on the ground. And when you talk to social impact investors, they will be asking you some of the same questions, like, do you know about the impact? What are the indicators? So that's why I think this panel today will be very interesting to understand financing, but also how do we support implementation of innovative models that we can then take to our funders and say, hey, we have the experience, it's cost effective, it's highly beneficial to populations, and so let's just plug the money in and scale some of these up. So I hope my third panelist, Dr. Gene Buckman, will join very soon. He is actually doing his hospital rounds, so you can appreciate that that's not so easy for him. But let me start with quick introductions. First, I have great pleasure to have Dr. Dan Chisholm join us. Dan is a social scientist with interests and expertise in public health, mental health, economics, and health systems research. He currently works as a mental health specialist in the Office of the Director, Department of Mental Health and Substance Abuse at the WHO. I have read a lot of Dan's work. I've really appreciated and used it a lot. And more importantly, Dan has been a core member of the WHO World Bank team that recently organized the International Dialogue on Health Financing for NCDs and Mental Health that just took place in Washington, D.C. And I hope today he's going to give us a little bit of an overview of how those discussions went and what were some of the takeaways, including Dan on innovative financing. It's also my great pleasure to introduce Kirsty Graham. Kirsty and I actually work together in UICC. And Kirsty is the Director of Capacity Building at the Union for International Cancer Control. For those of you who don't know UICC, it is really one of the largest civil society organizations and advocates for cancer. It has more than 1,000 members globally. And Kirsty is working on capacity building And in addition to that work, Christy also drives UICC's work in women's cancers, which particularly seeks to support the translation and implementation of the WHO Global Breast and Cervical Cancer Initiatives. And she has a PhD in cardiovascular research from the University of Sheffield. And I'm not sure if Professor Buckman has joined us, but I'm going to introduce him in any case, hoping he's going to join just in time to answer his questions. And then the third panelist is Dr. Buckman, who is a cardiologist and cultural anthropologist. He is the founding director of the Center for Integration Science and Global Health Equity at Brigham and Women's Hospital. And he's also associate professor of medicine and associate professor of global health and social medicine at Harvard Medical School. I think many of you know Gene from his work on Penn Plus, which has been working on, and he is strongly involved in implementation research worldwide. So I think we'll just kick off at this stage. So I would like to start with Dan. Dan, really welcome today. Thank you for taking time from your busy schedule to join. So Dan, you participated in the WHO World Bank team for the International Health Financing Dialogue. And during this conversation, one topic that kept coming up is that external financing for health is tight now. And there's a lot of discussion that financing for NCDs and mental health should not be vertical, it should be integrated. But in that context, what also came up is the role of external assistance as being catalytic. So Dan, could you tell us a little bit about the overall messages from the dialogue, and also what does catalytic financing mean, and how is this relevant for our work in NCDs and mental health? Over to you, please. Thank you.
Great. Thanks very much, Savani, and good morning, good afternoon, everybody. Pleasure to be here, and thank you for the opportunity to give a perspective from WHO's side. As you mentioned, I work in the Department of Mental Health and Substance Use at WHO, but very much reflecting the voice of several departments, actually, not least the Health Financing Department, but of course also the NCD colleagues led by Bente Mikkelsen, who's actually, it's her last day at WHO today. Perhaps before I come directly to your specific question, I should maybe give a little bit of context, might help the discussion we're going to have over the next hour. And then just to say, I think the context for all this is that, as we all appreciate, not only the public health, but also the economic impact of NCDs and mental health conditions are already vast, and of course will continue to grow, not least as a result of population aging, increased risk factor exposures, and continued underinvestment, as we'll discuss. And that we know leads to millions of avoidable premature deaths. It leads to, for example, around 1 billion people living with pain and other impairments, often unmet needs for mental health care, and actually trillions of dollars of economic output foregone through not least lost productivity in the workplace. So that's the kind of backdrop to all this, and really important to kind of emphasize, I think, in any of these arguments, that this is not, it's not an option just to kind of carry on with the status quo, because the problems are just going to mount up more and more over time. So the pain and the costs are just going to become further and further out of reach to address. So the other point is that a lot of the work that's being done, including at WHO and through various projects like the Disease Control Priorities Project comes to mind. We know what works, and we know in fact even what things cost and what impact they will have if interventions were rolled out and made available. These NCD Best Buys, for example, and a series of return on investment studies that have been done globally as well as in many countries to demonstrate the impact. So we have the evidence, but that is not enough, right, to guarantee the availability of appropriate financial investments into the services that are needed. So that is the basic, rationale and background for a meeting like this, which really is trying to bring together different stakeholders to discuss and better understand actually the situation and what are the feasible options open both to countries themselves, but also to external donors and other partners. So that's what I want to say about the backdrop. And I mean, this meeting took place back in June, and you and many others, were listening in or part of it. Took place in June at at the headquarters of the World Bank, not WHO, co-hosted by the two agencies, and we're joined by many other UN partners and bilateral and multilateral development organizations, civil society, and people with lived experience. So maybe one thing I'll put in I'll do it when I finish, but one thing I'll put in the chat, if that's available, is the link to some of the background papers that we commissioned in the run-up to this, and also a kind of summary of what the thinking was going into the meeting. So that'd be very helpful for people with more interest to go and have a look at that. But I'll just focus on what sort of came out of it, and I'll get eventually to the question that you asked me about catalytic funding. But actually, that's one part of the overall discussion. Before we get to the kind of external parties and donor assistance and what they can do, I think two really clear messages that came out of this is, I mean, one is more around the kind of system design and how many countries and their health systems are not well geared or designed to actually to provide preventive services or high quality longitudinal care or indeed financial protection for people with chronic conditions, NCDs, mental health conditions, and other chronic conditions. So I think that's a very strong, important message, that before we get to the actual sort of financing, I mean, the actual provision needs to be re-geared, redesigned, so that that helps to meet the needs of the population, but it's also talks to the efficiency side of things and how health systems need to be better targeting their available resources towards where there is the greatest actual burden of disease and unmet need. Then another message was around the need to kind of not think outside of the siloed thinking. There's no point just saying we need more money for NCDs and mental health. That's not going to wash. So we've got to really think of it in a much more integrated way, and not even restrict ourselves to the health sector, but actually think of NCDs, mental health, chronic conditions, NCD risk factors, as actually a development issue. And what that means is that we need to situate that in overall public financing systems and policies, so that we are able to tap into society-wide availability of resources, not just an allocation from the health budget. Then I think when we talk about the phrase sustainable financing, what do we mean? Really, what a lot of people said is that does mean domestic financing, because at the end of the day, development assistance for health, external support, it can play this catalytic role, which I'll define in a moment, but it ultimately should not and cannot replace a country's own responsibilities to plan, mobilize, and allocate the resources needed for promoting and protecting the health of their populations. So I think that came through maybe quite strongly, and a bit of a sea change perhaps compared to 5-10 years ago. So if we come to the catalytic role of DEH, of course that it still has an extremely important role in this, particularly in low-income countries and in emergencies, where without that external support and assistance, maybe over some period of time, really we know that not a lot is going to happen or change. So, but at the same time, because of this need to kind of keep the sustainability in mind, we don't want to breed more dependency of countries and we know about some of the vertical programs from the communicable disease areas. So we're talking about, catalytic funding that is able to be, it's almost like earmark funding, that it's there as a time-bound allocation that is very much linked to the country's own health plans. It's not coming from some external proposition. And it should be there to kind of accelerate or enable those national actions that have already been identified but are currently under-resourced to really, get off the ground, and use those funds to kind of overcome known barriers to implementation, typically systemic barriers around human resources. It could be around even capital, or specialized, diagnostics, or, things like that. We have lots of examples where catalytic funding has made and is making a huge difference. But we don't want to fall into the trap of making that a kind of never-ending, and then countries don't absorb and take on and embed that and make it mainstream those investments and make it part of their own national policy and service delivery. So I'll stop there. Sorry for going on a bit too long.
Perfect. No, Dan, that was a very good kickoff to this discussion we are having. And I think what struck me in what you said is sustainable financing embedded in domestic financing also means that the government has ownership of the agenda, and the country has ownership of the agenda. And that's actually a perfect segue to a question for Kirsty, because Kirsty recently led a very interesting policy document on integration of women's cancers around breast and cervical. And Kirsty, just picking up on Dan's point, we know what the best buys are. The WHO has talked about PEN, there's PEN Plus, and we'll come to that. But then when rubber hits the road, there are some issues regarding doing it on the ground. And your report shows that civil society organizations who are intrinsic to country ownership as well are doing this on the ground. So Kirsty, can you tell us a little bit about what are some of the things you found in the report, including what are some of the challenges that civil society organizations that are based in the country face when they want to scale up such interventions? Over to you. Thank you.
Thank you, Shabani, and thank you just for the invitation to be on the panel and the question. And Dan, excellent points. I was also taking notes, many points that actually are things that I will also mention, because really, really interesting. So I think, whilst Dan also mentioned this, I just want to touch upon the fact that, within this broader conversation of financing NCDs and mental health, I think it's really positive and useful to look upon some of these green shoots. So that's how someone referred to it in a recent discussion that I was in. And I really liked it because I think within this conversation around financing NCDs and mental health, it's massive. There's so many components, so many diseases. Even cancer within NCDs isn't just one disease, it's many. And so I don't want to deny the fact that there isn't huge investment required and a huge effort to be done around further integration across other NCDs. But I do just want to touch upon and leverage some of the experience and learning that we've seen from our community to date to inspire action and further momentum on this topic. So Shabani, you referenced this recent report that we launched on integrated approaches for women's cancers. It was launched at the World Cancer Congress in Geneva a couple of weeks back. And before digging into a few examples that were in the report, I thought I'd just give you a bit of background as to why we developed it, because I think that's really important in understanding, one, what's included, but also the kind of context which Shabani touched upon. So for UICC, one of the primary reasons for developing the publication was this apparent gap between what we saw in the experience of UICC member organizations working around the world, and particularly we were able to survey organizations in 3 regions, where when you talk about integration, it's not so much even a term that's used. It's just how services are delivered. It's just the way it is. They have limited resources, they have people trying to access care, and they treat the person. So it's really, they look after people with a view focused on the needs of the individual, as opposed to one set of targets, one disease, one strategy. And UIC operates very much with its network and with its members. As Shivani said, we have over 1,100 members. We have more than 50 partners. So we kind of checked and challenged this view or this perception that we were kind of coming across with many in our network. And it was really clear that this was a view shared by many, that this apparent gap between this kind of global conversation and these dialogues which focus on one disease and one set of targets, but also that there was really limited guidance as to how to integrate and what the evidence available was, and the potential challenges and benefits in actually integrating services. So the publication basically sets out and includes real-world examples and insights as to how integrated approaches could support improved cancer control. And particularly, and this came across very much in the stories and insights and experience we found of greater people-centered care, how it really supports that approach. The publication includes a whole section around different aspects of service delivery, but then also aspects across the health system, policy, financing, data, governance. So I just want to mention a couple of points that Dan, you mentioned, you know, when we know what works and we know what the impact is, absolutely. And we have the evidence. And Shivani, at the beginning, you mentioned, you know, what are the models of care and how do we actually do it? And I think what this publication seeks to do is to really bring out some of those examples, both from a financing perspective, but also in terms of service delivery, and just provide some of those insights and opportunities that there are, and also highlight some of those areas where we do need further evidence and guidance. So just bringing in a couple of different examples. So first of all, there's been some great work done in the WHO Eastern Mediterranean Regional Office, where they've developed an investment case on women's cancers. Particularly breast and cervical, which is very much the focus of this publication. And the investment case seeks to support policymakers to understand the burden of cancer in economic terms, but also to consider relevant interventions as investments, so not costs, but investments in health. So the investment case showcases to governments the cost of inaction, but also the return on investment of spending more on prevention, screening, and treatment. So just one statistic, of which there is many in the case study, the return on investment for HPV vaccination is $2 to $6 for every dollar spent. But the whole idea of this investment case is really to support governments looking across, in this case, 2 cancers, but really work towards this integration of at least these 2 cancers. Another example, which really highlights some of the points made already in the panel, is there were 2 people. We had a panel and a session at the Congress when we launched this publication. And there was a representative there from the Rwandan Ministry of Health, and then another representative from India. And in Rwanda, they have the Rwanda Women's Cancers Early Detection Program. And in India, there's case studies in the publication around the delivery of breast and cervical cancer. And both of these really highlighted this importance of country ownership, country-owned plans in supporting integration and financing. And it was a really fantastic illustration. There was a question around, you know, well, funders are giving funding around cervical, or they're giving funding around breast cancer. And they really highlighted that actually, if the country partner, the ministry, is pushing for integration, it is possible, and there are ways to advocate for it if it is underpinned by a cancer control plan, integration across policies at all levels, and really strong guidelines. And they had examples of how they'd done that. So I think, yeah, coming back to that point, Dan, that you raised about country ownership, political will is absolutely critical. And it's clear that there are examples from around the world of how this is done in terms of country ownership. And then I think just to touch upon 2 other different models that are mentioned in the report and in this session where we launched the report. So one is around I think it's important to mention the inclusion of cervical cancer in many traditionally communicable disease global funders, such as Unitaid, Global Fund, PEPFAR, given the links between HIV and cervical cancer, with women living with HIV 6 times more likely to have cervical cancer. I think there's obviously a challenge in there as well. We've seen that in some cases, this can add to the stigma associated with cervical cancer because of the link with HIV. But I think it is positive, and it's a good step forward to see that cancer is being included in some of those global funding streams. And another final example, which I'll end on this question, is around the public-private partnership models. It's important to note the kind of efforts made by WHO AFRO with support from Roche to support implementation of breast and cervical cancer services across Côte d'Ivoire, Kenya, and Zimbabwe, and also through its Empower clinics in Kenya. Roche is delivering both breast and cervical cancer, but also alongside other NCDs, such as hypertension, diabetes. It is an integrated, and it's very much a woman-centric approach. And I think these are just some examples. I know there's many others out there and others highlighted in the report, but I hope just illustrates a few of the kind of positive indications of how we can begin to move the needle and begin further integration.
Thank you very much, Kirsty. And also thank you for bringing in some examples, because I think I'll come back to this topic as what does it take to scale good examples? Because, you know, that's where the rubber hits the road on some of these interventions. There are a lot of pilot interventions, but then they collapse. So we'll come back to that. But I think now I would like to turn to Jean, because Jean is also implementing something very interesting. And for NCDs, we know that primary healthcare is important, but referral is important. The district hospital is important. And I think, Jean, in the work you're doing around Pen Plus, which is really looking at models of implementation for disorders like type 1 diabetes or rheumatic heart disease, etc., you are learning a lot. But as you're learning, where do you see the topic of funding coming in if you wish to scale this in a country, say, for example, Rwanda or any of the countries where you're working? Over to you, Jean.
Thanks, Sarbani, and Dan and Kirsty. It's great to be on here. And Keith, thank you for organizing this session. So yeah, and thanks for everybody for joining. So I'll just say that, you know, just to give a little bit of background on the efforts that we're part of. So I co-chair what's now a 23 country network with another physician, another cardiologist, Anna Makumbi, at the Universidad Eduardo Mondlane. And this is a network that really grew out of a Lancet commission that Anna and I co-chaired between 2015 and 2020 that was building on the work of a community of people that were focused on this problem of the intersection of extreme poverty and non-communicable diseases and injuries. And I think that the real message of that commission and that was coming out of that movement is that NCDs, in fact, are among the poor, a very heterogeneous set of diseases, and they don't lend themselves to the kind of single disease or small number of risk factor approach that had really predominated global public health over the last 30 or 40 years. So it really wasn't the case that if you just focused on hypertension on the one hand, or a disease like diarrhea as had been effective in kind of other paradigms, or even a risk factor like tobacco, that this would actually address sufficiently this very heterogeneous set of issues. So that was sort of one, is how do you address the great opportunities, the many different kinds of very cost-effective interventions that exist in that space. And then on the other hand, there's the issue very much of this gap in financing, and that we had, I think all of us would really hope that when the UN high-level meeting on NCDs happened in 2001, that it would continue this wonderful progress that had happened in the first decade of the 21st century that, you know, we now call the golden age of global health equity, with the big increases in development assistance for health for HIV, and that was the feeling was that was just a start. Now we were going to address all this other unfairness in the world around health. And in fact, what we had out of that meeting in 2011 was a paradigm that very much was saying these are all, you know, kind of self-inflicted preventable problems that are associated with development and lifestyles, and that, you know, all that was really needed was prevention, and that financing wasn't even like needed, you know, like, you know, or if you needed financing, maybe it was for, you know, policy change. And in fact, actually, like when we look back at the investment case on financing that was made, and Dan probably remembers this in 2011, the truth is it wasn't even that. It was like all that we need money for is statins and blood pressure drugs. That's essentially, you know, there was like sort of an $11 billion estimate of what the cost would be, and it was all like basically, you know, on, you know, the cardiologists really monopolized that agenda. And so we had a very cardiometabolic paradigm that was designed essentially out of the European office of WHO, that was based on the experience of higher income countries and being applied to poor income countries and low income countries in a way that didn't really respond to their epidemiology. And so then the solution is what we come to call integration science, which is that there's a need for, on the one hand, the design of integrated integrated delivery models that go beyond single interventions, but are meaningful, that are meaningful chunks of the health system that can be scaled. They're scalable units that lead towards progressive decentralization of services. And then on the other hand, you need integrated social movements. So you need to think about who really cares about these issues and is going to mobilize the resources, because, you know, in the end, you know, we have not seen much progress based on the existing categories that we have in global health. So, you know, categories around just, you know, human rights and universal health coverage have not seemed to have mobilized resources. There's not a constituency for that. And on the other hand, like even terms like primary health care, universal health coverage are not mobilizing resources. And NCDs, as we've seen, is a category that has in fact kind of diffused any kind of energy around mobilizing resources. So where the energy is, it seems like, is potentially the diseases themselves, the disease communities. Be they, you know, people that care about cervical cancer or breast cancer or type 1 diabetes or sickle cell disease, or you know, it could be congenital hydrocephalus, but they need to be aligned in ways that are meaningful, that are in combinations that are linked to service delivery models, because you can't mobilize people around, you know, NCDs. It's meaningless from a service delivery standpoint, and it's meaningless from a social movement standpoint because it's such a heterogeneous set of issues. So when we talk about Penn Plus, this is really an example of this kind of integration science for global health equity that we're pointing to, and we think that there's opportunities for this in women's health and other areas. But, you know, essentially what this is an example of bringing together the type 1 diabetes, the sickle cell, and the childhood heart disease communities around an effort to train nurses and other mid-level providers to manage those conditions, and then to equip them with the equipment, supplies, medications, and space that they need. And then to do that together with countries, implementing partners in a way that's scalable. And this is something that we've been, you know, working with the Rwandan government on for maybe about 20 years. And the last 10 years, it's really taken off in a number of other countries. And then in 2022, all 47 countries of the World Health Organization's African region approved this as their regional strategy, Penn Plus. And as the NCDI Poverty Network, we're really the engine that's driving expansion of this now. From 14 countries to 20. We had the launch of the Penn Plus Partnership Strategic Plan with Regional Director Moeti from WHO Afro, from the head of health of UNICEF, all the major organizations that focus on these three sets of diseases in New York just this last week. And we're trying to meet country demand. And so we project that probably at scale, this is going to benefit from, you know, several hundred million in external financing. And right now it's getting about 20. And that's really, you know, a very manageable kind of partnership. If you think about the scale of current development assistance for health, maybe being about like $40 billion, that, you know, in terms of like an example of how you grow this in meaningful chunks, we think this should be doable. And it's really a matter of, you know, delivering high quality services to the poor, and as financing is a barrier, making sure that it's not a barrier. And I'll just say that I think this is hopefully a way out of what I see as like a very frustrating kind of discussion around health financing right now, that is to some extent seems like very like kind of inward looking in terms of I would say almost like to some degree like whining about the problems with global, with global health initiatives and like problems with their governance, rather than like celebrating the fact that they're being sustained and are like saving lives, and need to continue to be sustained, and kind of denying the obvious truth that low-income countries just don't have the domestic resources to be able to finance equitable healthcare, and that the actual crux of the problem in global health is how do we move that money? How do we augment that? It's not how do we squeeze more out of some of the most under-resourced health systems in the world. So I think that this hopefully is going to be a breath of fresh air in terms of this sort of approach to integration science for global health equity. And I would really hope that the women's health movement, the women's cancer movement, also picks up that kind of a baton, and really work and really does the work of raising the external resources that are needed. I mean, it'd be wonderful if these were raised domestically, but that's not actually what the global community is needed for. Like, we're not needed to be out there like saying that, right? Like, that's sort of obvious that, like, yeah, it would be great if economies grew and there were more domestic resources. What our jobs are, I would argue at a global level is to redistribute resources from high income settings to where they have more utility in the poorest places in the world. So I'll drop my mic with that.
Great.
And I have to
No,
go back
Jean,
to rounding here on patients in Boston, but
okay.
yeah.
Great. No, I think Jean, you made two critical points. One is that there's still a lot of misunderstanding, and even including in the countries where we work, that NCDs is among the poor, that it is an issue of poverty. I've heard from countries who said that when they went and talked to parliaments, when the civil society organizations went to parliament to talk about NCDs, they said NCDs is a rich person's problem, including in our country, so they should pay for it. So I think there's some work to be done also internally in countries to raise the visibility of the poverty and NCD relationship. And I think the second point, I really like your point about integrated social movement, because I think based on everything I'm hearing from all of you, a lot is happening in the space, but if it's fragmented or there is no united voice around it, we will not be able to raise the visibility of it with, as Key said, with all types of financiers, whether it's domestic, international, private, philanthropic, etc. So with that, I'm going to turn to Kirsty. Jean, you're going to drop off, right? So
I am. I apologize. Thank you all.
No worries, but thank you. Great comments. Thank you very much. So then Kirsty and Dan, we have both of you, and I will concentrate on both of you. So Kirsty, I'm going to turn to you. I think this concept of integrated social movement, and what is UICC's take on this? What is the UICC doing around health financing? And also, Carrie Adams, the CEO of UICC, did attend the World Bank WHO dialogue in June. And what were some of his takeaways, and what was his advice to the teams there in Washington when he was there? Over to you.
Thank you, Shabani. Yeah, I equally like this term of integrated social movements, and there's certainly some examples that I can share with you soon. And certainly the social dimension of it is so important if we're going to progress with the integration agenda as well. So yes, as you mentioned, UIC was one of the few civil society representatives included in the WHO World Bank financing dialogue. To be honest, many of the kind of reflections that we had are kind of some of those that Dan shared earlier. So, I mean, we felt really this importance of country-owned plans, which I kind of touched upon before, the need to improve domestic financing alongside these other funding modalities, the catalytic funding, but particularly also the support that civil society can play. And I think maybe because we haven't touched as much on that, I'll just mention a few things about that. Coming back to the report that we did, as I mentioned, integration for civil society isn't so much a thing. It's just how it is. And so then when you move into the topics around that kind of other roles of civil society, I think it's important to recognize that this perspective really continues into their other roles. And I think, civil society's role in progressing the financing agenda is particularly through advocacy, but it's also around the sustainability and the effectiveness of investments. We have examples where civil society are holding governments to account, as well as increasing the access and reach of services, so touching on the efficiency of the resources provided, and they do this through demand generation, raising awareness, building those social movements. So in the Philippines, this is a fantastic example of this. We have quite a number of member organizations in the Philippines, and they are a relentless force. They are amazing. We have basically a group of organizations who came together many years ago now as the Cancer Coalition Philippines. Now, you have organizations in that network who are focused on childhood cancer, on breast cancer, and many other types of cancers. And they basically come together and they have defined an advocacy agenda, and they have been working on this for years and years and years. And they have so many significant wins that they have achieved in the country. So they really work with this collective perspective, and a massive achievement for them, it was around 2018, they secured the National Integrated Cancer Control Act. This is now supported by the National Integrated Cancer Control Committee, of which there is a representative of the coalition. Now, the person who sits on there is actually involved in childhood cancer, but they represent the views of the cancer community more generally across the multitude of different diseases. So, and also particularly in terms of some of the financing wins, they've managed to increase recently an increase in their Z benefits package. Now that is the kind of, it provides support for 6 types of cancer care and treatment, and they did that for breast cancer. And they've also contributed significantly to the decision to double the budget of the Cancer Assistance Fund, which really reduces out-of-pocket expenditure for cancer patients. They have commitments from PhilHealth, which is the health agency, to increase coverage for cervical cancer treatment and care, to include HPV DNA screening in its outpatient benefit package. That's really important for the progress towards cervical cancer elimination in the Philippines. And notably, as you know, I've been following along the work of the Philippines for a number of years now, funding was also allocated with part of these increased allocations in 2024 under the Prevention and Control of NCDs initiative for mental health patients and medications. So whilst they have specific interests, one in specific cancers, they're working collectively for improved cancer control and improved investment in cancer. They also are working through these different mechanisms to support increased investment for health. Another example, which is from one of the recent projects we were involved in, is in Guatemala. So in the last couple of years, again, it's a very, very active civil society working as a coalition. They've managed to secure funding for HPV testing in 10 departments of Guatemala through the reproductive health budget. And this is supported by the tax on alcoholic beverages. So it's another example of how civil society is helping to secure funding through budget advocacy. And some of the wins that I've just mentioned were achievements of the UNITAID-funded Success Project, which was a project focused on the implementation of secondary prevention of cervical cancer. It was led by Expertise France and implemented in partnership with JPIGO. And the whole project included a number of different pieces of work around health financing. A piece that UICC led, particularly in 2022, was we commissioned ThinkWell. So it's a health financing consultancy organization, Shivani knows it well, to develop a series of country profiles on the financing of cervical cancer elimination. Particularly, yes, it's useful for national level stakeholders, policymakers, but also for civil society working out how to advocate for improved financing for elimination. Now, whilst all the profiles, it was the context of the project, was focused on this financing for elimination, actually, many of the policy asks, the policy actions that they propose in these recommendations were to support increased investment in health and UHC more broadly. It was really teaching civil society the different ways to look at the financing space and work out how to advocate and how to engage for it, to engage with it. And we did some training as part of that as well. And again, Dan, it kind of touched upon some of the points you made earlier. It looked at kind of 5 different, what we called kind of policy dials or financing dials around sufficiency. Are there enough resources for health? Efficiency, are they being well used? Effectiveness, are they actually delivering the services of quality that they say they're going to deliver? Equity, who's accessing them? And transparency, are people able to see what's being spent? And so whilst I do agree with Jean that there's obviously challenges in increasing domestic financing, there are opportunities where you can look across these different areas of financing and look at how we can increase or even incrementally domestic financing for health. That's just a few thoughts, Shabani.
Kirsty, I particularly appreciated your bringing in some good country examples, because as you said, we are moving from the global, the theoretical, it's good, we must do this, to how countries are actually doing it. And so maybe now I'll take liberty that Dan has 2 hats here. He represents mental health, but he also represents the WHO, World Bank, International Dialogue. So actually, Dan, I have 2 questions for you. The first is exactly on this country ownership and how are we going to leverage country examples to maybe support countries across to learn from each other and perhaps support each other in driving the health financing agenda? And then how do you see the role of the World Bank and WHO? So that's my first. So why don't you answer that? And then I have a final capstone question on mental health. Over to you.
Okay, thank you. Well, I think all of these organizations, you know, whether it's WHO, World Bank, UICC, other organizations, actually can already point to many enough examples of good practice, how things can be done. So, I mean, yes, we can always. We need to continue that exchange of existing knowledge, but somehow it's not enough, you know. And so what do we need on top of that? And you know, I feel like it's, at the end of the day, it's about getting beyond some of this, the normative work that we see a lot of, you know, the sort of the costing and return on all of those kind of studies that they show you, but they're not implementing. So at the end of the day, they're still somewhat sort of hypothetical or promoting an idea, but not actually doing it. And of course, if you have a neighboring country that is doing a fantastic job, you can go, as the neighboring country, go and learn about that experience and see how they did. So it's about the how. And so when we come back to financing, we need to get a bit beyond the, what I call, you know, getting beyond cost effectiveness, demonstrating that something's worth doing. It's a good value for money. And, you know, the health package design, there's a whole thing about making sure NCDs are in their health packages. But if those health packages actually are not financed or they don't get implemented, so we need to get into that space about, you know, the nitty gritty, the guts, you know, the operational side of financing, whether it's the planning, links to broader development agenda. And there was a lot of focus at this dialogue around strategic purchasing, you know, so what does that mean, and how to ensure that NCDs and mental health around the table. Many countries, there aren't people working in mental health who are at that crucial moment where some of those critical strategic decisions are being made. So then it just continues with a bit of money for the asylum and nothing for the, you know, for anything else. So so that's probably, you know, what I wanted to say to that first question. And let's move to the, if you've got one more quick one before we, you know, Q&A.
Sure. So, and then we have a couple of, actually, we do have one question, so I'll come back to that. So, so Dan, really good points, but basically what I'm hearing is we have a lot of work to do with the countries. And we all have to be talking about country implementation, learning from that, sharing on the how, not just the what. Now, on mental health also, you know, at the high level, there is acceptance that there's a bidirectional relationship between mental health and NCDs. But then how do you see some of these understanding being translated at the country level into integrated programs? And is it only happening in high resource settings, or are some low resource settings also looking at integration of mental health with NCDs?
Okay, thanks, Sabani. Well, that's right. There are a lot of close links between NCDs and mental health conditions, whether that's the sort of shared determinants, you know, and some of the risk factors, but also the shared kind of consequences or impacts in terms of not only public health, but economic burden and so on. But if we also think about the comorbidities that exist between, for example, diabetes and depression, or cardiovascular, people with cardiovascular have a high double risk of depression, for example, and you know how to manage that rather than treating pathologies, but treating people. So actually, we've done many reviews of the available evidence, and of course, collaborative care comes out strongly as one of the more appropriate models for integrated, person-centered care, and that can address both the mental health and physical health needs and comorbidities in general healthcare settings, as been shown in many high-income countries. So actually, we are just finalizing a new manual on how to implement collaborative care in the context of mental health services. So that's sort of demonstrating, our sort of belief in it as an appropriate model. But I think the big question is, there's lots of research from mainly high-income country settings, some low-income, but showing that collaborative care works. But again, it comes back to, does it really work in a new, low resource setting with very restricted resources? And so I perhaps it can bring it full circle and just say that, I mean, this is the kind of thing which would be a very good use of catalytic funding from external partners, because it is new, it's innovative, and there is a cost, right? The main problem with collaborative care, not problem, but need, is the human resources. You've got to basically hire someone else to do the follow-up. Some countries don't even have a follow-up system at all. So you're bringing in something really pretty substantially different and new to what's there at the moment. So that takes a lot of time, effort, resources, and engagement with partners. So I think that could be a good example of how catalytic funding can be used to demonstrate or the value, or maybe not, of an integrated model like that, and use that to share experiences with other countries.
Perfect. Thank you both. I think that was really fantastic. And Key, I really appreciate that today is the 30th of September, because now we have really 12 months to the UN high-level meetings. And I think we should organize a financing dialogue every month, because we'll be building the messages for 2025. So I think my key takeaway from this discussion is that there is a need for in-country data and evidence on how to do things and what works, not just knowing what is cost effective, but actually doing it on the ground. And of course, that raises questions of what can you do in the short term, what can you do in the medium term? But again, there are some good examples like the Philippines and others that are doing it that we can learn from. And we did have one question, which is actually exactly around that point, which is how can researchers in Africa get support to do this type of implementation research on the ground? And of course, that's very important when country researchers do this work. It's very powerful. So for Kirsty and Dan, one source I do know is the Global Alliance for Chronic Diseases. Yeah, because they're really taking this very seriously, but there may be others. Maybe I go to Dan first. Dan, do you know of resources where researchers can tap into funding to do implementation research? on NCDs
Yeah.
and mental health?
Yeah, I mean, the Global Alliance, does for chronic includes mental health in its sort of portfolio, and the point is that it is an alliance of like-minded, research funding organizations. So I think that is a good place to start, because you've got everyone from the US and Canada and the UK and other partners. So you can immediately see who are the people part of that, and there are many of the big players. One example, we've been having discussions with the Wellcome Trust from the UK, who have mental health, for example, as a key priority. And it's a sort of continuing discussion, I would say, because some of these research funding bodies, their main preserve is around generation of new exciting research, discovery research, and that's maybe not quite the same as what is needed on the ground, which is implementation research. So it can be a challenge, I think, a need to kind of work with those research funding organizations to press home, I think, the utter importance of implementation research. Otherwise, too many of the interventions which are being shown through their own research funding to be effective don't actually get used where they're most needed.
Thank you, Dan. Kirsty, what about UICC and other civil society organizations? Do they support such sort of operational research?
Thank you, Shabani. 100% agree. I think implementation research is just so critical. And I think that was one of the points, I think, behind this publication, is that actually many of the organizations who are implementing integration are not the organizations that have the funding or the skills to then write a publication about it, or to conduct research that then could be published. But they are doing the work and they are implementing integration. And so, yeah, 100% agree that we should be doing as much as we can to try and support this data from the country perspective. From UICC's role, we do have calls for applications on a regular basis. We awarded actually implementation research projects in Europe earlier this year. We'd love to have more of them. We also have calls for individual researchers through our fellowships program to support training and development of skills. And there was one other, and we are really hoping that off the back of this publication on integration, we are able to, in a number of months' time, open a call to support organizations for the implementation of integrated approaches, but also through the gathering of data. So we don't have anything right now, but definitely watch the space and hope to be able to offer something like that in the future. And there are some other calls coming up that can support individuals.
Perfect. So I think that was a great panel. Thank you, everybody. And I would like to end with the role of academia, because academia is part of the integrated social movement, and a lot of academia will do implementation research. And it's going to get published, and talking to policymakers will mean. So with that, I'm going to hand over to Key to ease us into the next section. But thank you very much, Dan and Kirsty. It was a great pleasure for me to host you today. Thank you.
Yeah, thank you, Sarbani, and Kirsty, and Dan, of course, Jean, for really expertly articulating the key essence of what we're talking about, which is, I think, over and over again, we're talking about integration, right? And not only at the policy level, of course, integration at the financing level, civil society action, and of course, at the end of the day, what patients see, integrated service delivery models, right? And the role of academia, for sure, we're going to do something about this, right? So just so you all know, we have our team on this call, and this is being recorded, and we will take tidbits out of this, the key, some pearls, and prepare an article to disseminate. That's what we do best, right? We'd be happy to do it. We'll be in touch with you, Kirsty and Dan and Jean and Sarbani. Thank you so much for your time, and feel free to drop off. I know you have busy days, and we're going to now transition to our second panel, which is right at the hour. Thank you. And there's Joanne. We were trying to figure out who's who. I think we all signed. I think the second panel signed in as Taylor Bournes. Taylor's
Yes.
great, and I'm glad to have multiple Taylors, but we need to figure out who's who. So Joanne, you're there. Sorry, I think I see two sorries, and then
Sorry
Malinga.
and Malinga, if you could turn on your video.
Great.
that
You're
would be
sorry.
great.
And Malenga, are you there?
Yeah.
Can you turn on your camera? And we need to make sure that his Zoom name matches his, there he is. So Malenga, are you able to change the name on the Zoom here from Taylor Born to You? If
Yeah,
not,
let
maybe
me-
Neil can do it for you.
Yeah, now I can rename it.
Okay, great. Well, thank you, Joanne and Sari and Malenga for joining. We're now going to switch to a very specific thematic area, women's health, and maybe even more focused on women's cancers, and look at how when we take a specific condition, how integration can happen in trying to develop sustainable financing strategies around this. And I'm really delighted to introduce Joanne Manrique. Joanne is the president of Center for Global Health and Development. She's a long-term practitioner of global health and also in the development space. We happen to be co-chairs on the Women's Health and Economic Empowerment Network. And I've had a pleasure to working with Joanne, and she's agreed to moderate the session with an impact investor who you'll introduce, and then also development expert. I love what Dan said about this is not a health issue. This is now we should reframe it as a development issue. That's how we get additional sources of funding and how to get countries thinking about this at a much more comprehensive way. So Joanne, I will turn it over to you now.
Thank you, Dr. Key. It's an honor to be here and then also to, join in this discussion with Sari Miller and also Malinga, both dear friends, but dear experts in the field. So I'd like to actually start with Sari, who has throughout her career financed and focused on mergers and acquisitions. She was a partner and CFO at a company that had over 1,000 employees and reorganized over $30 million revenue. I think most importantly to this discussion as well, she was an angel investor into Leapfrog, and Leapfrog now, as you know, does a lot on microinsurance in development in Africa and other markets. And really, it looks at the implementation modeling of what's needed for women's health, because we need an ecosystem approach of how we deliver impact in women's health. It can't be just, healthcare. It can't be just hospitals. It's renewable energy. It's panels. It's also the microinsurance that's required for the affordability of it. And, I think thanks to Sari now, Leapfrog is almost $3 billion raised and in terms of its growth. So I think based on the earlier discussion, in terms of the domestic mobilization and what's needed from a country level, I turn it around to some of the experts, and I like to turn it over to Sari. Sari, over to you. And I think the question here really is, how do we make, as Dr. Key was saying, that implementation happen from a private sector perspective into women's health and get the capital and resources that are needed beyond just the vertical investment into an ecosystem approach that's sustainable over time and doesn't fail within 3 or 4 years. Over to you, Sari. Oh, we can't hear you.
Thank you so much for having me. And just give me a second. I'm sorry. I've got to close out mine. Okay, I think this will work better. My early background was both in investment banking. I got to see a lot of deals in mergers and acquisitions and how things work. And these were highly for-profit deals, and with a multiple on revenue or net operating income. Separately, I had another life as president of this huge organization. They needed to be reorganized since they lost this $30 million AT&T client. And I was able to reorganize the company in about 15 months and get back on the approved list. So I've actually seen both the transaction side and very deep into transformational operations. About 17 years ago, decided to totally focus on impact investing in for-profit companies. And always felt that if they are for profit, even at a smaller profit, some of them, that they would keep their eye on the ball, and that they would be very careful with low or resources and much more effective. And they were not as distracted by really raising money every year from donors. So the first transaction I did in the space is I backed a young entrepreneur who had an idea for a do-good fund. And that became Leapfrog Investments. Leapfrog Investments is focused only in emerging countries, mostly Africa, India, and Southeast Asia. But we felt that we didn't have to sacrifice financial for social returns and vice versa. So you have to be very careful in the companies that you get involved in. And typically we look at who the founder is and get a sense whether we think they can execute, and that they are so utterly committed to their company's success that they won't give up and that they can rely on the ups and downs. So Leapfrog Investments started out in a new asset class called microinsurance, not microfinance. We felt that little bits of insurance would give the poor a safety net so that they could take some more risk. So for instance, they could take a risk on some new seeds for agriculture, because if there was a 5% risk of it failing, they had some insurance so they could take on that risk, which may have in fact, and has in many cases, provided, much larger returns. It took us a while to move from property and casualty microinsurance to health insurance in these emerging countries. And what we found typically is it obviously pick a country that actually has some healthcare network. So for instance, Leapfrog invested in Good Life pharmacies. It was very hard to get confirmed, genuine medicines into pharmacies. And we therefore had to start with the supply chain, and the founder and president of that company was high integrity, and he was looking for expansion. Typically, the pharmacy is the doctor in all these villages. But Leapfrog today is approaching $3 billion, and we've made many investments in healthcare companies. Supply chain is complicated. Legitimacy of drugs is complicated, and obviously lack of trained manpower is complicated. But there's a huge world out there, and we can have tremendous impact. Should I continue about some deals in general in the space? Or
I think we'll turn it over to Malinga, and then we'll go
Okay.
into very specific practical examples from both of you. So I'd like to turn it over to Malinga, dear friend, and then also an expert in a lot of that's been done on supply chain management, having worked both with Crown Agents, Africa Resource Center, many of the African countries, and been representing African countries in a lot of the different deals that are brokered in terms of what we call innovative financing. But I think what the countries basically call creating healthcare ecosystems, right? Because this financing is part of the natural way that they build their infrastructure, and how they aggregate and create cooperatives for women to be able to work and be able to supply themselves with a salary, but also be able to supply healthcare as healthcare workers. So Malinga, I wanted, based on the discussion earlier, because I know you were listening to the earlier panel, in terms of what you're doing, from a country perspective, we always say, COVID-19 is over, but it's always left a lot of supply chain issues for women's health, and also that require now a lot of innovative financing solutions to solve. So I was wondering if you can comment to that a little bit based on your experience in working with the countries of Zambia and Kenya. Malinga?
Thank you very much for having me on this one. Yeah, can you hear me?
Yeah, now we can hear you.
Can you hear me? connect. Yeah, okay, okay. Thank you very much for having me on this panel today. And definitely, this is a topic that is grappling most of the African countries. We know that NCDs impact most of the least developed countries worse, and especially after COVID-19. One aspect that has been positive from COVID is obviously the emphasis on mental health has been getting a lot more prominence. Now, with regards to looking at innovative financing for NCDs, we all know that governments are not able to fully fund, the primary healthcare envelope for most of the countries, and in particular, just take it with how can we stretch their already constrained resources, and and more with the community health workers and empowering them a lot more so that they become the first line of defense. I think we're also looking at providing diagnostics so that we do not lose women in particular. They can also be attended to at a much earlier stage. Previously, what has been happening is that, say, for instance, for cervical cancer, women would come in to the hospitals, the tertiary level hospitals, when they're stage 3, stage 4, which is very late. So government, together with other cooperating partners, has been looking at innovative ways of ensuring that women are attended to at a much earlier stage. So again, it comes back to diagnostic. The other innovative ways of doing this is that we've now been looking at involving the telcos as well. So you've got telemedicine being used. Money is never going to be enough. That is the bottom line, is that we have to now deploy and employ new ways of dealing with NCDs across the board. In some cases where government has gone in, is basically assisted in working with women's cooperatives to empower them, and thereby, whether it's through a hammer mill, they can get some extra resources, which then can also allow them to be able to attend to other primary healthcare facilities which are not available in their localities. So there's a number of ways of doing it. I mean, we've tried to increase our current public health insurance scheme, which is inadequate, and by involving other even private sector insurance schemes to come on board. So it's like stretching the dollar or stretching the current resource envelope. It's not adequate. Yeah. I mean, there are many ways of looking at it, and I know that even in Kenya, it's the same thing as well, where the government in Kenya working with us, we've been looking at more innovative ways of getting more people to be insured.
And Malinga, I think you froze for a second, but I think you were saying in Kenya, there's, more innovative ways to get insured. And so I think I'd like to turn it back over to Sari, while, you unfreeze there for a second. In terms of, you mentioned leapfrog and some of those practical experience, are there other examples that you can look at, in the continent and how this innovative financing is being done for women's health? Sari.
Okay, I think in all of these projects or initiatives, you definitely need to start with grants and concessional financing. But a lot of this is really powered by donations. So and the pharmaceutical companies like Merck have put in millions of dollars geared toward women's health. Part of what's helped with these companies is the growth of, the teleconference market. And as was alluded to, we find that the access in rural areas has now gone from zero, that last mile, to using smartphones or borrowing someone's smartphone to actually make a huge difference for access. So, but the Gates Foundation has put in billions of dollars for women's health, and they have been more focused now on outcomes. So, for instance, but everything is a blended finance model, and Gates is used for both its extraordinary funding, but also in help in last mile access, since they usually have offices on the ground, and they have networks, whether they be religious associations, to actually get the care out. The other piece that you spoke about had to do with early diagnostics. And I'm one of the founding investors in Nevia. It turns out that about 75% of ovarian cancer cases are diagnosed at late third stage or fourth stage, where it becomes very, very difficult to treat. And they are working on treating it through vaginal secretions and have found biomarkers that might be helpful in early diagnosis. And their concept, which is in a number of these companies, is to use something that looks like a sanitary napkin that in the pad itself would be able to diagnose early abnormalities, and would be kind of used monthly. And it would be, in the privacy of one's home, and obviously have, confidentiality to it. But that work, takes many years and lots of funding, both to get the science right, but also to get through regulatory agencies. And it's a slow grind.
Yeah, no, thank you. And I think that's where, putting together some of those innovations and also the financing required for them. We talk about blended financing, but it's really getting it to the last mile. When we look at those innovative financing examples that have been done, as you said, in some of the countries, but also, in maternal health, there's a lot of examples, because you mentioned Merck. I know Merck for Mothers has done a lot of blended financing. But Malinga, in your opinion, how does some of this innovative financing to do with women's health actually get to the last mile and not here at 50,000 feet, but really to the woman who needs it on the ground to, in terms of delivering a baby or having access to breast cancer screening? In your opinion, how do we get there?
Yeah, I think also just building upon what Sari has just mentioned about the last mile. I think what we've also seen that works very well in both Tanzania and Uganda is, that in every little small town or village, there's always going to be somebody who owns a drugstore, and incorporating those drugstores so that they could be able to provide the needed healthcare commodities. So it's not just, most of the 90% of healthcare provision in most African countries is government-led. So there's 10% which is private. But what the government has said is that everybody has to be a partner in terms of finding better solutions. So those health shops are now being integrated in the formal service delivery, so that those who need healthcare products can actually go to their local healthcare shop, who are then, the healthcare shop is registered under the pharmaceutical or regulator of the country, and be put on the delivery shed from the central point of delivery of pharmaceuticals from central medical stores, for instance. They would be able to then deliver to the health shop, and the clients who are based around the health shop are then able to go and receive their, their products from the health shop. So it's also in more of an innovative way of working with the private sector. So nobody is left behind, because in most cases we do not have enough health facilities, or rather the clinic may have run out or is slightly too far away from where the clients are staying. So the health shops in a village, in a small community, are being integrated as part and parcel of public health provision. That's another way of being innovative in places where you do not have the infrastructure in place. But you will find, I mean, for instance, we always say you can find a Coca-Cola in the most remote place in any country. But why shouldn't we find drugs or commodities that will save lives? So we've been working with the likes of Coca-Cola or the local bottlers in the country to provide that last mile distribution, which is so critical.
Thank you. Thank you so much. And I think in terms of that last mile distribution, some of what the other panelists earlier talked about is really de-siloing some of the approaches of, how we are focused on investments. And one of the things we are looking at within the Women's Health and Empowerment Network, also with the help of Dr. Key. So Dr. Key, I turn it over to you as well to jump in, is when we looked at this, and you guys are the experts, Malinga and Sari, it's also looking at de-siloing the fact that there's climate money, right? And then there's solar for health money, which is not really climate money because it's more solar for health focus, but then there's also money for a primary healthcare package of services. So at WEN, what we're doing is uniting all those dialogues, but also uniting some of the financing so that we can streamline how we deliver care. If you're going to put a solar for health facility, you put it where there's a primary healthcare package of services that maybe some of the companies that we're working with will be delivering, but then also getting investors at the table who can scale it even further beyond grant money is necessary. So I agree with both of you. And I think some of these innovative approaches is really where we see some of what is going to evolve to be the future of how we do healthcare systems. Dr. Key, I'd actually like to turn it over to you to add anything else.
Yeah, no, thank you. I'm listening, but since you picked on me, you talked about looking at solar, women's health, right? These are, so as the development community, health community starts to prioritize certain things, that trickles up to the funders, governments, banks, right? And now we're at a place where I think women's health, women's cancer is really and as it should be, a priority for everyone. I love that. Then we now have climate change, which has become, obviously through lots of advocacy efforts, but rightly so, a priority. How do we combine those two things in a sustainable financing model for delivering let's say women's health, right? So let's pick Zambia. Zambia now has, it's one of the countries where the vaccination for cervical cancer is I think they'll start soon, but it's not preventing the cervical cancer cases. And I think it's fair to say that the number one cause of death for women is cancer, cervical cancer. So how do we detect those cases early, and how do we treat them? All right, we have a moral responsibility to treat these cases that we detect. And, partnering with the government, where now they have the social health insurance scheme that Malinga talked about, and that provides a baseline of reimbursement or payment for some of these services. Can we start thinking about a women's health health center that is able to provide early diagnostics all the way to treatment? There's a revenue model that comes from out-of-pocket as well as government reimbursements or payments that makes it attractive enough for people like Sarah Miller to say, you know what, this is will be revenue generating to the point where it's self-sustaining and is scalable, right? Those are the kind of things that I think that excites me the most right now.
So I was involved in a company called Mobile ODT, and what that company's products were is it was the initial product was focused on diagnosing cervical cancer. It turns out that most of the almost over 90% of the cases are based on HPV. And it was a very portable unit that had a cell phone attached, so you could take the images right in the field. And we organized with the Minister of Health of Kenya so that in different rural areas, we bus the women in to one central tent place, and we'd have about 10 tents, of which 9 healthcare workers, you didn't have to be a physician, would take the images, and the 10th tent would be to do cryosurgery. It turns out cervical cancer is a great cancer to address quickly because we do have an effective vaccine, and it takes about 5 years to actually become full-blown cervical cancer. And it's a young women's killer cancer with high morbidity as well as mortality.
And in that instance, how did blended financing or concessional capital de-risk your investment there and other investments? Because I think frequently the DFIs are looking for more advice as to how they could catalyze these types of investments, especially as you said, since cervical cancer is so preventable and issues of women's cancers. So how can the DFIs do more in those areas, or how have you used their capital in the past?
Well, we found that you needed a lot of grant money and other companies who are interested in maternal health to fund the early research work. The big innovation at Mobile ODT was there's a huge sort of stationary device to do colposcopy. And the patents were related to handheld devices in the field with low internet, and if the phone and the device was charged, we didn't even need electricity. But it took it was only toward the end that we were able to get financing for it. And companies like Leapfrog, so that's a fund, they would look for, when they're penciling out a project, they're looking for at least a 15% return on investment. Now, if you look at, that's on the financial end of it. If you look at the social impact, when we look at dollars spent, we're looking at a multiple impact on the social side of somewhere between 5 and 10 times return on investment, which is a very high bar. And both components needed work for private financing to come into place.
Thank you. And I think a little bit of the domestic financing, the development financing is also activating the domestic financing. And a lot of times, Malinga, you mentioned earlier, kind of the ecosystem around that, but how do you get the country to really want to mobilize that domestic financing in partnership with the investor or in partnership with the DFI? That's quite a political process sometimes, and some investors don't want to take the headache to go through it. So how do you work with the governments to get them there?
Yeah, I think working with government can be a headache, but you know what? Once you've got the policy in place and they see the return on investment, it becomes much easier. It's just basically getting the regulatory framework in place. Things do work. They take slightly longer, and I know that where policies are sound, money comes for it. Where the policies are vague, money shies away. And it's all about convincing various partners to just come on board. I think once you get 1 or 2 across the line, it becomes much easier. I was just from last week's roundtable when we were being told like investment in scaling up of cancer care, for every $1 spent, you get 12.45 globally, and it's 21.39 in Africa. There is a need because the return is greater than that we're putting in. So government is aware. It is to be probed continuously and finding the right partner. I think it's like once you find the right partner, things do work, and I'm just basically listening to Sari. I'm saying to myself, how can we get you to Lusaka, and look at different alternatives of making those financing mechanisms possible. This is a key area for government to look at both, not just NCDs, but cancer care. They're putting in money, but it's just not enough. And it's not coming in all at once either. It's a long-term strategy, but it needs to be done.
Yeah, and I think a long-term strategy is really where all of us need to work together from the first panel to the second panel. And that, the short term is a combination of that grant capital, as Sari was talking about earlier, the concessional capital that the governments have to activate. In the case of the Women's Health and Empowerment Network, we've been working with Indonesia because they received $4 billion for diagnostics, but really it's not about the $4 billion deployment, it's about the gap. And in essence, they have a gap about 1.3 billion to surround that 4 billion investment. And so sometimes it's not lack of money, but really what is the surrounding business model for deploying the money you do have at the table more accurately and efficiently, so that it does get to the last mile, but also so that we can all work together in not a 3 or 4 year goal, but a long-term goal where 10 years from now, there's sustainability for women in terms of how they get their care, their medical diagnostics, how they, go in terms of the long mile. And so I'd like to turn it over again, to Sari in terms of how do you look at that long-term planning? What advice would you give, when you were at the roundtable at UNGA, what advice would you give some of these governments as they're not looking at the 3 and 4 year plan, but we look at the 10-year plan, of how to move beyond affordability of the medical diagnostics that are necessary in the treatment plans to a 10-year plan where we're looking at the future of how younger women get into the cycle of getting screened, treated, and that they can afford care.
So a few things. Yes, you need like a 10-year plan, which obviously always changes after a few years. So part of that is, and that's both on the public and the private side, is to be resilient and flexible in terms of changing governments. And you need, in the early days, you need to make sure you have very strong advocates in the government or closely to like the Minister of Health to advocate for your project. 10-year plan is clearly the vision, but no government is going to look for that kind of long-term gains. So you need to have midway, even earlier, like in the 2-3 years, of what does success look like, and to keep this attention and commitment going. So 10 years is great, but I think we need to always have milestones for year 3. And the first year, sadly, takes a long time to get anything moving. And so you need some like early wins, early execution, early, numbers. So separately, I am one of the founding investors in Akagera Medicines, which is a US corporation, but it's majority owned by Rwanda. And their issue, there's 2 things that we are interested in. One is delivery systems we have a very unique patented delivery system that helps even be more effective with the mRNA vaccines. But we're also looking for care, both in terms of getting vaccines out globally. I mean, our initial mission was to cure TB, which has never been, the cures right now are not really working, and they're so toxic that people never complete the course. But because the NIH is working on 7 indications, we've expanded to HIV and Lassa fever and RSV and so on. So, but the other goal there is to really build out manufacturing of vaccines in Africa, of which only 2% of vaccines during COVID were ever produced there. So that will be, an extraordinary, getting HPV vaccines, manufactured on the continent will be extraordinary. So that's one end of it. Prevention is kind of an important thing, but people looking for impact statistics fairly early on. So when we have a vision, we need to sort of focus on early wins.
And just going off your point in terms of, some of that regional manufacturing, what you're talking about in terms of, the countries having capabilities to do their own vaccines. Malinga, in terms of your experience working with countries and some of these blended financing structures, how are you seeing, regional manufacturing? I mean, it's key to how we do blended financing to women's health. It's key to how we develop some of these markets and ecosystems to make them sustainable over time. But what are you seeing in terms of the questions and statements that Sari mentioned as an investor on the continent?
Yeah, sure. When it comes to regional manufacturing, I think out of all of the 54 countries would like to manufacture commodities on the continent, but we've also have to look at scale. I think currently there's probably 2 facilities on the continent that can manufacture vaccines, one in Senegal and the other one in South Africa. I mean, clearly, Africa CDC, is looking at, bringing that manufacturing closer, most likely somewhere in East Africa. However, I would say, like to say that it's better we sort of concentrate on the 2 particular areas where we already have the expertise, the Pasteur Institute in Senegal and the facility in South Africa, and maybe bring them up to a level that they can actually satisfy the supply of vaccines for the majority of the continent. I do not think that we will have that capacity in the next 2 to 3 years or so, but we can build upon that and ensure that there is value in having 2 large manufacturing sites on the continent, one in East Africa, one in West Africa, one in Southern Africa. Yeah, I mean, that's really our take on manufacturing. I know there's a clamor for more manufacturing facilities, looking at the population of Africa, which by the year 2050 is projected to be 2.5 billion. So every 4th person on the continent, every 4th person globally will be from the African continent. So there is value in ramping up, but there is also value in ensuring that we can satisfy the majority of the market from those 2 facilities that have been highlighted as regional manufacturing facilities. Having said that, I just wanted to go back to one point that Sari brought up. I hear you on the 10-year sort of pipeline. Yes, in Africa, there's always changes in governments. Government ministers are not permanent. And what I tend to look at is how do you then develop a better, sort of like a broader access of partners, basically hedging. There's always going to be somebody who will be changed. You don't want to lose that momentum. In our kind of setting, it's always good to also get the the first lady more involved because there's stability there. And, obviously the first lady has the husband's ear in most cases. So having several champions, not just reliant on one minister, because that minister will be changed in any time. So you have to develop a way of safeguarding to these shocks, as I would put it, and making sure that there's a lot more people that are involved and are knowledgeable on what needs to be achieved.
Thank you, Malinga, for
Hope
that
that
point.
answers your
Yeah.
question. Yeah.
It does. And I'd like to turn it over, back to Sari to comment on what you just stated. I think it is, we can't have it, dependent on one political figure. Sometimes, I actually have my own opinions as we've seen the Women's Health and Empowerment Network, is that what we find is that the financial relationships and platforms that are already in the countries, as we've been brokering some of these solutions, allow us to not have to worry about political transitions. I mean, they do cause a lot of instability, but if you have the right financing in place through a private equity fund, or through a private equity fund that has a technical assistance arm associated with it. And there's many equity firms that have done that nicely in some areas of the continent, including, Africa Invest, Phillips is doing some of that work in the Transform Health Fund. So as long as there's a financial vehicle sometimes already in place, it prevents some of those political transitions. But I completely agree with you, Malinga. It can be totally disruptive. So over to you, Sari, since you're the expert investor on some of this, as to how we deal with that political instability as we're financing women's health on the continent.
Well, historically, financing women's health and even doing clinical trials with women has been sorely lacking. And on the other side, on the fund side, women-led funds get only about 2% of the investment. So there are many things to fix on that behalf. I think it's a great idea about first ladies getting involved, and you get beginning to see that in like the UAE and in Saudi Arabia, where there is a lot of money. And if the women can get the ear, unfortunately, of their spouse and create a powerful network that will bring money and commitment to women's health and cancers. And, women are, if the women are unhealthy, there's a tremendous impact. Even though they may not be the big earners, they actually make everything in the family level and run. And they're effective there's a whole cascade of issues that fall as the primary woman's health declines. So anyway, so yes, I'm all for that. Ministers change all the time, and the politics change, but we got to get a compelling, committed people who don't care who's in power.
Yeah, that's true. And we do have some questions on the chat that I'd like to go to in just a second. But I think one of the key things that we've also seen as the Women's Health and Empowerment Network is bulk procurement as an answer for potentially some of what could be done in terms of both private sector investment and blended financing to solve basically gaps in both diagnostics and treatment. There is, of course, some controversy because companies don't want to lower their cost of diagnostic treatments or diagnostic tests in order to do bulk procurement. In maternal health, when we worked on some bulk procurement at CGHG, we found that it did alleviate some of the gaps in services around maternal health, specifically when we worked in Tanzania. So is there an area of bulk procurement, and I'd turn this question over first to Malinga and then over to Sari, that we could see as, being some of the future steps of how we do blended financing for some of the areas in both Africa and Southeast Asia. Malinga, in your experience, what have you looked at with the country?
Sure. Yeah, I mean, when it comes to bulk procurement, I mean, definitely that is another way of bringing the unit price down. I think together with WHO, they're looking at various facilities and Africa CDC, various facilities on the continent that can be bulk holding centers. So that, I mean, in most cases, most African countries buy from the same source, but at varied pricing, because obviously we're not utilizing we're not leveraging our population adequately, and the more we do that, the more we can bring down the unit price and start now getting better pricing from the actual manufacturers. I mean, I can tell you that when Zambia procures essential drugs coming out of India, Malawi does the same thing, Zimbabwe does the same thing, and we've been saying that that just those three countries, once upon a time they used to be in a federation, and together right now they would form about 60 million inhabitants. If we would buy from the exact same source, we would bring that unit price down, but we're not doing it as countries. But there's a lot more discussions now going on. It's like, let's start doing bulk procurement, and not at emergency level. Because we obviously, when it becomes an emergency and you're looking at bulk procurement, it's still going to be 2 to 3 times the normal price, because it's an emergency. But if you plan for it adequately, and the disease pattern in most of these countries, so there is need to expedite that bulk procurement.
Sari, over to you. What are your thoughts on some of the bulk procurement in terms of an investment perspective?
Well, interestingly enough, we formed Akagera Medicine so that we would hardly make money in emerging countries, and that but the rest of the world we would charge just like the other companies. So we really have a dual model, but we don't have an approved vaccine. We just started clinical phase for TB vaccines in the last month. But that's our plan, and in the background we're working on huge distribution. TB we think of as being in emerging countries, but there's lots of cases of TB around the world, and in the United States, for instance. And but the NIH has encouraged us to do things like MRSA and do MRSA and get involved in other diseases that are, a much rest of the world, if you will.
Thank you,
But
Sari.
most companies are not like that. Yeah.
I see a question in the chat that says, will countries pay slightly more for locally, regionally manufactured products? I'll turn it over to Malinga and Sari on your experience. What we've seen through the Women's Health and Empowerment Network is we've seen innovative financing models where you could trade on futures. For example, you could trade on the futures of grain, and the countries will probably and have paid more for ARVs a couple of years back to trade on futures. So in essence, the future trading, I think, is one financial mechanism that countries have used in the past to do this type of acquisition of products. I don't know, in the case of the ARVs, they did pay more. They weren't locally manufactured, but they did pay more. Malinga and Sari, over to you.
Just talking about ARVs and the procurement of it. I mean, most of the procurement of ARVs on the continent is actually through PEPFAR and the Global Fund. And because they're negotiating, and Unitate, because they're negotiating better pricing because of the volumes that are being bought, so they get better pricing that way. Now, if a country goes on its own to try and buy ARVs, obviously it's going to be at a much higher price. Going forward, do we, can we look at locally manufactured ARVs? I think the first issue here would be the acceptance from the clients. Is the quality equivalent to that is being procured from outside? I think there's a lot of work that still needs to be done to ensure that one, quality is as high as those that are coming from outside. Two, acceptance from individuals who are on ARV treatment or TB, for instance. Before I hand it over to Sari, I just wanted to talk about the TB side, Sari. You know that most of African countries are in the extractive industry, okay? And clearly TB is one disease that can hamper any kind of mining. So there's always, before miners go down underground, they have to be tested and when they come up, because otherwise that can shut down a mining operation. And it most likely, probably it would be a good idea to go to some of these large mining companies, conglomerates on the continent, to look at volumes in terms of testing. Can they buy from the locally manufactured, rapid test for TB? That will then create that volume. Also they need it anyway. So you would get the volumes. And if it's the right price, and I'm sure most of the mining companies would go for it. Thank you.
As we all know, TB is often subclinical and then periodically manifests, so that extractive industries, that's a great case for us. What I think once, critical, as I agree with you, that you need to make sure that the manufacturing of drugs and vaccines is totally at the same quality as foreign sourced product. And that is something that companies have been working on to test both the even the baseline right now is the legitimacy of the drug, and then to to compare it to whatever is foreign sourced. I think you need more manufacturing facilities, because periodically, as we've heard, some facilities become compromised, both on quality and on power, in terms of losing power. And you have to store some of these vaccines and medicines consistently, and which can be problematic. But I think that there's going to be a savings from just transportation and supply chain, which will make a huge difference. But the volume would be terrific, and that, yes, it would be key to get a buying federation across different countries.
Thank you. I know we're coming up on the hour, so I'd really, like it to turn it over to Dr. Key again. I think a little bit of what Sari and Malinga you discussed is really looking at a holistic approach and blended financing mechanisms that incorporate many different parts of the ecosystem, including vaccine, healthcare workers, microinsurance, diagnostics, and innovative tools. And making sure it works in low resource settings. As far as next steps, I hear you saying, both of you saying, this should include bringing in additional partners for parallel investments to continue to de-risk and scale what we have to date, and also looking at initiatives that unite sectors for funding, such as climate and gender. And getting everyone to speak the same language is sometimes what's needed for these blended financing models, and also implementations, and just brokering the solutions. And so really it's an honor to have, moderated this panel. And as co-chair of the Women's Health and Empowerment Network, we look forward to working with the countries and also the investors, Sari, as yourself, and Malinga, yourself as an implementer, in trying to get these solutions across and really brokered and scaled. So over to you, Dr. Key.
Thanks, Joanne, for excellent moderating and even better summarizing. You did a great job. I'm going to talk a little bit about the vaccine, because you guys spent some time on it. And I'm hoping there's some people here on the call who are sort of innovators because we need people to think outside the box. So for instance, the vaccine, we talked about local manufacturing, but one of the most exciting things about vaccines that really help in the LMIC setting is the idea of heat stable vaccines, right? So there's some examples of it already now, which is vaccines typically need to be stored in refrigerators or now even freezers. But imagine if you can store vaccines on a shelf. And then that simplifies transportation, storage, and lowers cost of logistics, thereby making vaccines much more accessible in those places with very little cold chain capabilities. I love that. So, could we have a heat-stable vaccine analog in women's health, right? And for me, I do surgical care or surgery. So thinking about tinkering on those things. There was one question on the that was put up by Bafor Awue. Hopefully, I'm saying this correctly. I loved his comment, and it really he talks about how do we get proof of concept demonstration projects that it really shows that by integrating these services and saving lives and could do it in a cost-effective way, maybe even a financially sustainable way, show that so that investors, development professionals, governments start paying attention to these things. I absolutely think that's really the next action step. And then my final thought is on integration. I think the first session was integration. That's a verb. And second session really talked about ecosystem, right? And we're not talking about an ecosystem of just the health system. We're talking about an ecosystem that looks more of like a market, right? What we see. If you're a patient, or if you're an individual living in an LMIC in Africa, let's say, for you or for that family, the public health system and the private health system is really fluid, right? We move in and out of those two systems all the time. And so we can't isolate ourselves to thinking about only the public health system. We absolutely need to look at the private health system and how do we drive equity, affordability, access in that sector as well? Because and that is the ecosystem where we need public money, donor money, private capital, and this is where we get that comprehensive strategy towards capitalizing NCDs. So those are my thoughts. Thank you, Sari. Thank you, Mulenga. Thank you, Joanne, for your excellent second panel. Thank you for those who are online who joined this last 2 hours with us. And thank you for the CUGH team and the PGSST team that's helped put this all together. Have a great day. Thank you.
All right. Thank you very much.
you.
Thank you.
Yeah.
Pleasure.
Yeah.
Thank you. Thank you.